mock exam. So today we will cover only CBA part. So first of all, this question is in front of you. Can you see the screen?
Yes, sir.
Describe this ECG and what is the likely cause for this ECG appearance?
It's idioventricular
We
rhythm
don't
field
have much time. Sorry, what are you saying?
idioventricular rhythm field basing.
Idioventricular rhythm. Okay. Okay. Any other thing?
It can be because of
The cause is field basing. I have seen some spikes or something like this.
Please speak loudly. In exam, you will have only 8 to 10 seconds to understand. Because there are 2 to 3 questions and you have less than 1 minute. Less than 1 minute for answering one question. And one question has 2 to 3 questions like in this. First question is describe this ECG. Second question is what is the most likely cause for this ECG appearance? So you have to answer this question in less than 1 minute. So 20, 30 seconds
This is a
maximum.
broad. It's a broad
complex.
ventricular complex ECG rhythm.
Broad complex.
Probably the patient had a heavy block for which he has been paced, either a second degree.
How can you see second degree block? Can you see the P wave here?
No,
Sir,
sir,
this
there
is
are no P waves, but probably this is a paced rhythm.
Paced rhythm. How can you say paced rhythm? Are you getting any pacing spikes?
Yes, sir, we can see the pacing spikes.
Where? You got? Can you see this is the pacing spike? This is the change of first to AVR, and then this is change of lead from AVR to AVR.
There's a lot of distraction in the voice. Maybe the internet quality is not up to the mark.
So we're not able to hear you properly, sir.
Okay, I will change some. Just a minute, hold on. In any case, लामा ही करना और कोई ऑप्शन नहीं अपने पास. Can you hear me now?
Yes,
Is
sir.
it better than
Much
before?
better. Yeah, it's much better than before.
Okay. So, where is the pacing spikes? If you are saying this is pacing spike, this is not the pacing spike. This is the change of lead from first to AVR, and this is from AVR to V1. So these are not pacing spikes.
Then maybe this is a fine wave of hyperkalemia or after intensive MI, rhythm.
Tanmay rightly said this is hyperkalemia. How can you see this thing? Because of regular bradycardia, 42 beats per minute, if you count the rates, and large stented T wave, absent P wave, and widened QRS. So you have to understand which pattern is this, because in ECG, there is not enough time to get the calculation of the rate, calculation of the rhythm or axis. You have to understand the pattern, because this is the broad complex tachycardia, but broad complex QRS with bradycardia, most probably hyperkalemia. Okay. Is there any confusion?
No, sir.
Yes, sir. Right. Agreed.
Agreed. Okay. So what is the next question? A healthy adult is brought to the emergency department having fallen onto a bonfire. The patient has a carboxyhemoglobin level of 5%. Would they be considered to have suffered an inhalational injury?
Normally,
Tell
up to
me.
10% normally can be acceptable, sir. So chances of inhalational injury are less likely. Up to 10% is normal in smokers as well.
Okay. What features in a
Yeah,
patient
10 to
with burn?
15% will be 10 to 15, I guess, is the level. And as you answered that it won't be considered as an inhalational injury. Apart from that, 𝒃𝒏 will not be used as a because we
What
suspect
features in
hyperkalemia.
burns would indicate need for early intervention? The change in voice, presence of hoarseness, stridor, presence of soot particles in the nose. These features will indicate that early intervention might be required. And 𝒃𝒏 in these patients, being a depolarizing agent, this multiplication of this baby nicotinic receptor. So
Okay.
its action can be prolonged, hence it is not indicated.
Okay.
From 48 hours to 2 years, it is not indicated.
So levels of up to 10% can be seen in smokers, as you rightly said, in urban environment. Also, the injury was sustained in an open environment. So chances of inhalational injury at the level of 5% carboxyhemoglobin is very less. Second thing, you rightly said, inhalational injury indicated by voice changes, hoarse voice or stridor, singed nasal hair or carbonaceous sputum, visible swelling or blistering of lips, tongue or oropharynx, deep burn to the face and neck, respiratory distress or respiratory failure, GCS less than 8. In these situations, you will suspect there may be some inhalational injury. And 𝒃𝒏 you can use after 1 year of post-burn. Okay. Okay. Should I move ahead?
Yes, sir. Great.
Okay. So next question. Who will read out so that you have some interest?
A 74-year-old man was admitted to the intensive care unit following an emergency laparotomy for a perforated large bowel with extensive peritoneal soiling. Post-operatively, he has been sedated and ventilated and has required vasopressor support. On your review, you note that over the last 2 hours, he has developed reducing urine output and a 50% increase in creatinine compared to admission, increasing vasopressor requirements despite optimal fluid status, reduced tidal volumes, intra-abdominal pressure of 24 millimeter of mercury. What is the diagnosis? Question A is, what is the diagnosis? How are the intra-abdominal hypertension and abdominal compartment syndrome defined? And how can intra-abdominal pressure be measured in the ventilated patient?
So this
So
is a
should I
case of
proceed with the answer?
Yes, please.
this is probably a case of abdominal compartmental syndrome, and intra-abdominal hypertension is.
How can you say this thing?
So we can see that he has been operated for a major surgery, and he has received crystalloid resuscitation, and after that there's a drop in urine output as well as increase in creat, which indicates that there's evidence of end organ hypoperfusion. So basically intra-abdominal hypertension is any pressure of more than 12 millimeters of mercury, but ACS will be anything more than 20 millimeters of mercury with evidence of end organ hypoperfusion with or without the abdominal perfusion pressure being less than 60 millimeters of mercury. And since he's a ventilated patient, we can measure it by using Kovn's method, where we have the insertion of a triple lumen Foley's catheter into the bladder and checking the pressure by injecting around 25 ml of normal saline, with the patient being in supine position and head in a semi-propped up. And at the end of expiration and zeroing to be done at the level of external iliac crest.
Okay. So, absolutely right answer, abdominal compartment syndrome, because there is a evidence of end organ perfusion hamperness. Okay. So when there is a evidence of organ dysfunction, like in this case, patient developed AKI, acute kidney injury, because of rise in creatinine, oliguria. So you can say this is a case of abdominal compartment syndrome. Intra-abdominal hypertension is defined as a sustained or repeated pathological elevation of intra-abdominal pressure more than 12. ACS, I already told, IAP more than 20 plus new organ dysfunction, which was not present earlier. And then there is a method to measure the intra-abdominal hypertension is indirect method via a triple lumen Foley's catheter in the bladder or a balloon tipped catheter inserted into a stomach. So you can use any of the method. So absolutely right. Next question. Who will read?
You are asked to review a 69-year-old man with low oxygen saturation and a 6-month history of breathlessness. 3 weeks ago, he developed fever and a productive cough of green sputum. You get his pulmonary function test done few weeks before. What category of lung disease is demonstrated by this low volume loop? What treatment is advocated for acute exacerbation of this condition?
Okay, tell me, Nishant, give me the answer.
So this is a flow volume loop, which is showing both the inspiratory and the expiratory limb. And we can see that there is a scooping in the inspiratory limb, which indicates it's an obstructive lung disease pattern. So probably it could be bronchial asthma or COPD.
So,
and for the acute exacerbation, we can use bronchodilators and corticosteroids.
Okay. So basically, this is a restrictive lung disease. How can you say restrictive lung disease or obstructive lung disease? How can you say?
Obstructive lung disease will have. We usually have a scooping pattern in obstructive lung disease.
Obstructive scooping pattern in the expiratory limb or inspiratory limb?
Inspiratory.
Inspiratory limb. Okay. So can you see the scooping pattern in this? Basically, if you feel a graph is shortened, okay.
Okay.
Or both inspiratory as well as expiratory, so this is a restrictive lung disease. Okay. If you find any scooping or problem with some expiration like chronic obstructive lung disease, then only you will say, see, this is a case of obstructive lung disease or a COPD. So in this graph, whole flow volume loop has been shortened. In a normal case, in case both inspiratory as well as expiratory limb will be higher than this. So this is a restrictive lung disease. Okay. And treatment is advocated for the acute exacerbation. Steroid will help. Okay. What is this? Who will read?
Yes, sir. It is a CT scan, which is showing to my impression. There is on the left side there is a large infarct, and along with that there is some brain atrophy apparent on it, and some hydrocephalus. We can say not too marked. Yeah. So this is what is the abnormality they asked. So this looks like a left-sided large malignant middle cerebral artery infarct. Which vascular territory is affected? As I mentioned, what is the relationship between systolic blood pressure and outcome in acute ischemic stroke? What is the relationship? Systolic blood pressure should not be reduced unless it's more than 220 millimeter of mercury in acute ischemic stroke. Yeah, that's the only relationship. Then we, if we are to thrombolize such a patient, then it should be less than 185, I think. If I'm not wrong,
185, 110 is the cutoff before thrombolysis. And post thrombolysis, it should be 180/105.
Okay. So before
During the thrombolysis,
thrombolysis,
it should be, yeah.
if
It
you are
should
not
be,
planning thrombolysis, then you will expect, you will tolerate the blood pressure till 220/110.
Yes. To
And
maintain the
if you are,
penumbra.
yeah, to maintain the perfusion of penumbra. And if you are planning for the thrombolysis, then blood pressure should come, should be less than 185 systolic and 105 diastolic. Okay. So what is the
and
recommendation regarding blood pressure control in first 24 hours?
first 24 hours, as you have mentioned,
24 hours of 15% of the mean arterial pressure.
Yes. So is a case of acute left-sided cerebral infarction, left middle cerebral artery, you rightly said, at a U-shaped hypertension associated with increased risk of stroke recurrence, whereas hypotension associated with increased risk of cardiac events. And NICE guidelines does not recommend lowering of blood pressure in the period except to facilitate thrombolysis in case of preeclampsia, eclampsia, aortic dissection, or hypertensive encephalopathy, nephropathy, and cardiac failure. Okay. So they ask about the blood cutoff blood pressure in a thrombolysis and in when you are not planning thrombolysis. What is this question?
This is most probably an MRI of it's look like I cannot comment. It's a T1 or T2 image. Shows a
How
large
can you say
infarct
this is
in the,
MRI? Why not the CT?
well, sir, it looks like an MRI. I
MCS
can't
syndrome,
actually-
sir, basically.
Sorry?
It's a malignant MCS syndrome.
Malignant
We can see
MCS
the
syndrome.
soft tissue surroundings, which are more which are, and the and also the hyper intense lesion is kind of showing more to, it's pointing more towards it being an MRI.
Okay. And
What syndrome do these appearance demonstrate? Yeah, it's a middle malignant cerebral infarct. And what is the evidence of decompressive hemicraniectomy in malignant middle cerebral artery syndrome? So as far as the decompressive hemicraniectomy in middle cerebral artery syndrome is concerned, there are few landmark trials like I don't exactly remember. There are 2 or 3 landmark
It is
trials.
Destimal Destiny and the Hamlet trials for MCA infarct.
Yeah, Hamlet
Whereas
trial,
for hemicraniectomy, we have Rescue ICP and the 𝐷EFRA trials.
exactly, Rescue ICP and the what
so
was
if
the
you
other
do
one?
if you do decompressive hemicraniectomy, what will be the mortality? Is there any mortality benefit? And what about the morbidity?
No mortality benefit, only the patient lands up in a more vegetative state. They had checked at the extended Glasgow outcome scale in these trials, where they said that there is no mortality benefit, but the chances of vegetative state and severe neurological disability is higher.
So basically, not like this case, basically, if you go for the decompressive hemicraniectomy, in this such type of cases, there is a mortality benefit, but disability will increase. Okay.
Okay.
So this is a malignant MCS syndrome. Hamlet trial showed that decompressive hemicraniectomy within 48 hours is associated with a reduction in mortality, but severe disability. It also demonstrated an increase in the functional independence at 6 months. Destiny 2 trial showed that in patient more than 60-year-old, improved survival was at the expense of severe functional debilitation. Means if you do decompressive hemicraniectomy, patient will survive, but he will be disabled. This is the crux of all the trials. Hamlet trial, Destiny 2 trial, 𝐷EFRA trial. So there is a definitely reduction in mortality, but increase in the disability. This is the important thing. Okay. Is there any confusion?
Well, sir, in the 𝐷EFRA and the Rescue ICP, there was no mortality benefit, but there was increased morbidity, just like these trials. Yani.
But
In these trials, there was mortality benefit, whereas there was
Yes.
increase in morbidity just like that. But in DACRA and rescue ICP, there was no mortality benefit even.
So look into that exactly.
Yeah.
But now the understanding is that if you will go for the decompressive hemicraniectomy, there is a reduction in the there is a mortality benefit, but disability will increase. Now this is the understanding.
Okay.